Welcome back, everyone. As you're taking your seats and we begin our tour through the cardiovascular system, I'd like to introduce our next speaker, who will be at the podium for the first time. Speaking to you about shock will be Dr. Bhakti Patel. Dr. Patel is an assistant professor of medicine at the University of Chicago.
All right, I have no relevant conflicts of interest to disclose. So at the end of this talk, we will be able to develop an approach to shock and how to assess it, and then direct a management towards the type of shock that you've determined. So broadly speaking, shock should be considered a circulatory failure. And when we think about all the components in the circulatory system, we think about the pump. So pump failure would be cardiogenic shock. There can be abnormalities in the fluid, such as not enough fluid, so hypovolemic shock. There can be abnormalities in the tubing that connects the fluid back to the pump. So there can be incompetence of the vasculature, such as in distributive shock, or there can be an obstruction of the fluid returning back to the pump as an obstructive shock. There are hemodynamic changes that are associated with this state, as well as clinical and biochemical signs that we'll go through. So let's focus on the hemodynamic changes. It's important to know that shock can be present in the absence of hypotension. It's not one is required for the other. And we'll talk about certain disease states where hypotension is sort of a manifestation late in the shock state. If we think about the components of the mean arterial pressure, it really is a product of cardiac output and systemic vascular resistance, such that hypotension sort of requires a decrease in either systemic vascular resistance or in cardiac output, or both. When we look for signs of shock, there can be some organ systems that you can readily interrogate at the bedside, the three being the brain, the skin, and the kidney. So patients with shock can develop altered mental status. There can be cold or clammy or mottled skin to touch. And then at the bedside, you can also see if there's any oliguria that is developed. Some biochemical signs that we rely on are lactic acidosis, primarily as a symptom of abnormal cellular metabolism because of loss of availability of oxygen. There are four main types of shock: those that are related to a decreased cardiac output, primarily cardiogenic shock, hypovolemic shock, and obstructive, and those that are related to decreased systemic vascular resistance, which primarily is distributive shock. By far and away, for those of you who work in a medical intensive care unit, 2/3 of the shock you see really is distributive and primarily dominated by septic shock. The others are sort of equally distributed cardiogenic and hypovolemic shock. So when you approach a patient with shock, there really are two questions that you have in your mind that can kind of create an algorithm of what type of shock it is. And so the first is the cardiac output high or low? If the cardiac output is high, you're really dealing with a distributive type of shock. And then the second question is, if the cardiac output is low, it could be either due to hypovolemia or cardiogenic shock, and so an assessment of volume status can be helpful. So this is the general algorithm that has been proposed and works pretty well when you're sort of going through these questions. The first is the cardiac output high or low? And then once it's low, is the heart empty or full? Full being cardiogenic shock and empty being hypovolemic shock. So let's talk about ways to determine high versus low cardiac output at the bedside. So in terms of the hemodynamics, I often rely on the pulse pressure as a surrogate for stroke volume. It can be useful to sort of get a sense of, does the patient have a high or low cardiac output? And so a widened pulse pressure would be characteristic of high cardiac output state. On exam, patients would be warm, they'd have bounding pulses. If you look at nail bed return or capillary refill, it can be quite brisk. In contrast, those with low cardiac output states actually have a narrow pulse pressure. They can be cool to the touch, thready pulses, and delayed nail bed return. if you've determined the patient has a low cardiac output state, a volume assessment is useful. You're going to hear more about this in the next talk with Dr. McConville, but just at the bedside, you can get an assessment primarily with a clinical history. Often if there's GI bleeding or hypovolemia, you have some sort of history cluing you into that. On exam, you look for evidence of high circulating or high circulatory overload with JVD or peripheral edema, rails on exam. Hemodynamics, really dynamic assessments of hemodynamics have been helpful in terms of determining volume status, and they work better than static measurements. And you'll hear more about that in the next talk. And then on an X-ray, you can tell if there's whether pulmonary edema or cardiomegaly that can clue you into volume status. Often a vascular pedicle can show up on the exam where they look at the distance between the SVC as it crosses the right main stem to the last branch off the aorta. And if that vascular pedicle width is more than 7 centimeters, it can be an indication that the patient has a high filling pressure. So here we have a question. It's a 75-year-old man with a history of diabetes and hypertension who presents with hypotension and is found to have an anterior wall MI. His blood pressure is 90/70 with a heart rate of 120. On exam, his extremities are cool to the touch. Which of the following would likely characterize as hemodynamics assessed by a PA catheter? Choice A is a decrease in the right atrial, pulmonary wedge, cardiac output, and systemic vascular resistance. Choice B would be a decreased right atrial pressure and wedge pressure with an elevated cardiac output and a low SVR. Choice C is an increased right atrial and wedge pressure, decreased cardiac output, increased systemic vascular resistance. And choice D would be a decreased right atrial pressure, wedge pressure, cardiac output, and increased systemic vascular resistance. So most people chose choice C. The way to sort of differentiate that's actually the wrong location. It's supposed to be choice C, that is correct. So the way to differentiate between the choices, a lot of times on the exam, they'll have ups and downs in multiple places to confuse you. So on this question stem, you know the extremities are cool to the touch. And so there has to be increased systemic vascular resistance, which then takes away choice A and B. And then the way to differentiate between choice C and D is that clearly the patient has a cardiac reason for a shock. And so this would be associated with high filling pressures, and therefore the right atrial and wedge pressure would be high. Okay, so let's go and talk a little bit about cardiogenic shock. The most common cause of cardiogenic shock that you'll see is left ventricular failure, usually associated with a myocardial infarction. If you think about the types of myocardial infarctions, ST elevation MIs have a higher incidence of complications with cardiogenic shock than non-ST elevation MIs. There's about 50,000 cases a year of cardiogenic shock that are seen. When you think about the pathophysiology of myocardial infarction, all roads really lead to ischemia. So in the setting of a MI, there's a decreased cardiac output that leads to a decreased coronary perfusion pressure, which then perpetuates the ischemia that was the inciting event. And in addition, you can have diastolic dysfunction with pulmonary congestion that leads to hypoxemia. Again, the cardiac muscle is very oxygen avid tissue, and so any hypoxemia can lead to more ischemia. And so all roads really lead to relieving the ischemia, because if you don't relieve the blockage, this ischemia cycle will continue, and then there'll be progressive cardiac dysfunction. And it turns out to be true in clinical trials. So there was this landmark paper done with subsequent follow-up studies, up to 10 years of follow-up, where they randomized patients to initial medical stabilization versus immediate revascularization. So initially, they didn't see at 30 days a mortality benefit, but if you follow these patients up to 10 years out, there's actually a substantial mortality benefit, primarily because there's preservation of cardiac muscle. So these patients don't develop severe congestive heart failure that has to be continuously managed. You can develop cardiac or cardiogenic shock from right heart failure. We often see that a lot in the medical ICU in the context of patients with severe hypoxemia. The clinical signs are slightly different. You still have an elevated JVP, but in contrast, you'll have clear lungs because it's right-sided disease, not left heart disease. It can occur in situations of increased pulmonary vascular resistance. So mechanically, there can be an obstruction related to a pulmonary embolism. And then often you can acquire this right heart failure in the setting of alveolar hypoxia, usually in ARDS, or you can develop worsening right heart dysfunction in the setting of high PEEP that's applied. Obviously, you can have right heart failure from a right coronary artery MI, as well as valvular disease or dysrhythmias. An echo can be really helpful, especially with the bedside echoes, to determine whether this is a right heart limited circulation or not. And so here you have what a normal echo would look like. The left ventricle is actually larger than the right ventricle. But in contrast, this patient with right heart failure has dilation of the right ventricle and the right atrium, and it seems, and the septum is now flattened, and there's impingement of the left ventricular filling. Next, we'll turn to a low cardiac output state, but now with an empty heart or hypovolemia. You can think of hypovolemic shock having sort of two etiologies, one with absolute volume loss, more typically due to blood loss or relative dehydration. You can also have a relative volume loss. Suppose there's often patients who actually have septic shock will present initially with hypovolemia because they have venodilation. There's a lot of fluid that's in the wrong location, like the skin or the mesentery. And then after you resuscitate the patient, it reveals that they have this vasodilatory state. So this is sort of the classic example where you can be in shock but without hypotension. So if we look at classification of hemorrhage by increasing amount of a hemorrhage here, you can lose a little bit less than 15% of your blood loss and still have a normal blood pressure and a normal pulse. And so it's really the tachycardia presents itself once you've achieved about a 15 to 30% blood loss. And then the blood pressure only drops once you've lost about 30 to 40% blood loss, assuming you have an intact cardiovascular system. So this is sort of a scenario where you can have a lot of shock, even with decreased urine output, with a normal blood pressure. To determine the volume status, again, you'll hear more about pulse pressure variation and CVP variation, which are dynamic assessments of whether the patient will be volume responsive or not. And the management is simple. Clearly you have hypovolemia. The choice is to stop the leak, whatever the leak is happening, and then also resuscitate the patient with the appropriate fluid. And so you target your fluid resuscitation for end organ perfusions, looking primarily at mental status changes, tachycardia, as well as urine output. And then you try not to overdo it because you don't want to create complications with hypervolemia with an over-aggressive resuscitation. And obviously there's no point to just pour fluid into someone unless you haven't fixed the cause of the loss of fluid. Let's talk about fluid choice. So this has been studied previously looking at different types of crystalloids. So the question is the use of hydroxyethyl starch for fluid resuscitation in comparison to crystalloid is associated with A, improved ICU mortality, B, increased rates of renal replacement therapy, C, reduction in ICU length of stay, D, reduction in duration in mechanical ventilation, or E, decreased bleeding risk. Yeah, so most of you have read the literature about hydroxyethyl starch. There have been a systematic review of multiple trials comparing crystalloid normal saline or lactated ringers to hydroxyethyl starch. And putting all those data together, found a relative 9% increase in mortality with the use of this resuscitative fluid, as well as a 32% increase in risk of renal replacement therapy. One study actually found increased bleeding rates with hydroxyethyl starch. And so this has largely fallen out of favor. So let's talk about another question. A 65-year-old man with a history of coronary disease presents with chest pain and shortness of breath 1 week after an anterior ST elevation MI. His vitals reveal a blood pressure of 70/50 with a heart rate of 120 beats per minute. On exam, his neck veins are distended with clear lungs to auscultation bilaterally and muffled heart sounds and cold extremities. His clinical presentation is most consistent with which type of shock? A, hypovolemic, B, obstructive, C, cardiogenic, or D, septic. Right, so there's a mix between B and C. I think everyone sort of correctly identified that this is a low cardiac output state based on the narrow pulse pressure. And then the question becomes, well, could this be due to a right heart failure syndrome because it's in the presence of clear lungs and hypervolemia, or could this be due to obstructive shock? The muffled heart sounds was placed there primarily to suggest that the patient probably had a pericardial effusion or tamponade physiology, and he has that 1 week period after a large ST elevation MI, so you could either have developed a Dressler syndrome or a free wall rupture, and so the answer was obstructive shock. So the physiology of obstructive shock is one of inability to have venous return or an increased ventricular afterload. And so the scenarios that we commonly encounter are really inability of venous return, either from cardiac tamponade, as was in the question stem, or potentially from an abdominal compartment syndrome. You can have tension pneumothoraces that can result in decreased venous return and obstructive shock, or worsening resistance to venous return, either from tumor compression or a large pulmonary embolism, or increased PEEP, either intrinsic or delivered by a ventilator. There can be scenarios of increased ventricular afterload that are sort of acute, which you can see in increase in pulmonary vascular resistance from a pulmonary embolism. Sometimes hypertensive crises can create this. I've seen this in the setting of pheochromocytomas where they develop obstructive shock from the large amount of afterload. So now let's move on to high cardiac output states or distributive shock. As a reminder, sepsis is the most common reason why patients present with distributive shock. The hemodynamics are related to having a large stroke volume or a wide pulse pressure. There can be decreased systemic vascular resistance. Some patients may also have a reduced diastolic blood pressure relative to their baseline. On exam, they have warm extremities, bounding pulses, will have brisk nail bed return, and then there'll be some sort of additional sign of an infection. Non-infection related causes of septic shock or of distributive shock include hepatic failure or pancreatitis. These can be sterile sort of inflammation with lots of cytokines that's causing a distributive physiology. You can also have high cardiac output states from a large AV or a AV fistula or Patch's disease or thiamine deficiency. The central tenet to management of septic shock actually is timely identification and eradication of the source of infection with timely antibiotics. There's been a large amount of literature looking at the timing of antibiotics, with the most recent New England Journal published this year looking at a cohort of New York hospitals that adopted a 3-hour sepsis bundle of certain landmarks or time points that patients should achieve. And they looked at the timing of initiation of antibiotics by the hours here, and then in-hospital mortality adjusted by the baseline risk factors. And as you can see, as the delay of antibiotics persists by hour, there's a 4% relative increase in death for every hour of delay of antibiotics. Interestingly, they also looked at delay of the first bolus or first IV fluid resuscitation, and they saw no association with mortality. That's not to say you shouldn't resuscitate your patients. It's just to say that resuscitating them without looking at the impulse for the distributive shock will do nothing for them. So you have to really think about what the source of infection is and try to treat to that. So here we have our next question. An 87-year-old man who presents with right upper quadrant abdominal pain is found to have acute cholecystitis on abdominal ultrasound. On exam, he is febrile to 39 degrees Celsius with a blood pressure of 90/50 and a respiratory rate of 26 breaths per minute. Initial labs are pertinent for creatinine of 1.5 and a lactate of less than 1. Based on the sepsis 3 guidelines, this patient's clinical condition can be best described as A, SIRS, B, sepsis, C, septic shock, or D, severe sepsis. Okay, good. So I'm glad I created a little controversy. The reason for this is this sepsis 3 guidelines, just for people who like random useless trivia, actually is one of the most downloaded articles in JAMA's history. And people are kind of really looking at this new definition. The old definitions included SIRS and severe sepsis, but this new definition really just defines patients as sepsis or septic shock. And so I'll kind of go through why these patients qualified for sepsis under the new sepsis 3 guidelines. So first, obviously, you start with someone you think has an infection, and then the question becomes, do they have some evidence of end organ hyperperfusion, which they sort of use as a screening tool with a Q-SOFA, which is a quick SOFA score. The SOFA stands for Sequential Organ Failure Assessment. And the reason it's called quick is that you can assess this by just being at the bedside without any laboratory data. And so the 3 criteria for the Q-SOFA are tachypnea, altered mental status, or systolic blood pressure less than 100. And so in the question stem, the patient had a respiratory rate of 26 and then also had a systolic blood pressure of 90. So now you've said, okay, this person, I'm going to suspect sepsis in. Once you do that, you have to actually quantify how many organs are dysfunctional by using the full SOFA score assessment. So the SOFA score here has 6 categories. The first is respiratory, second is your platelet count, the third is your bilirubin, cardiovascular would be blood pressure and need for vasoactive agents. You look at the patient's central nervous system, so as assessed by GCS score, and then the kidney function. Often you don't have an ABG, so it's sometimes hard to then get the PF ratio, but the bar is set quite low with only 2 points. And so this patient had a little bit of hypotension. The MAP was less than 70, and also had a creatinine of 1.5. So now they have 2 points to qualify to say that they have sepsis. To then qualify from sepsis to septic shock, the authors of these definitions really wanted to say that shock requiring pressors was severe enough to sort of put patients in their own category. So if patients have a serum lactic acidosis of greater than 2, which this patient did not, and also if they needed pressors, then they would qualify for septic shock. So let's think about resuscitation of septic shock. This sort of landmark paper published by Manny Rivers in the New England Journal now 16 years ago really set the standard of what we thought of how to resuscitate patients, and the idea being that you should resuscitate them early within a 6-hour window, and that resuscitation should be guided to a volume status by looking at a static measurement of CVP of 8 to 12. And once that was achieved, then you would then turn to see if the patient achieved their MAP goal of 65 and above. And then finally, once all those hemodynamic parameters were achieved, to then assure that the patient achieved a mixed venous saturation of at least 70%. If that was unable to be obtained, then you would transfuse them or start dobutamine. And then once those goals are achieved, you can proceed to hospital admission, because this was an ER study. This initial data suggested that there was a mortality benefit from this intervention, but what we've learned in the years in between is that all these goals are somewhat imperfect. And so we'll talk about these goals one by one. So I'm sure all of you are aware that there was a re-demonstration of this trial done at 3 sites, one in the UK, one in Australia, and then one here in the United States. The United States study was the PROCESS trial. What they looked at was recapitulating Manny Rivers' protocol, but then compared it to, is it really the protocol he chose, or does any protocol matter? Meaning having some sort of algorithm of how to resuscitate patients, is that the power of the mortality benefit? Or should we just do what we normally do with usual care in our best judgment? Now, this trial was repeated 13 years after the Manny Rivers trial, so usual care, I hope, has improved. And so what we found was that there was no difference between the three strategies, that early goal-directed therapy did the same as usual care and did the same as this other protocol that they derived that primarily relied on a lot of IV fluids. But there are some lessons to be learned. First is that if you look at, on this left-sided panel, the rate of central venous catheter insertion, obviously the patients in the Manny Rivers trial, about 100% of them had a central line placed within the first 6 hours because that was required by the protocol. In comparison, the usual care and the protocol-based therapy, only about 55% of the patients required a central line, and yet they achieved the same outcomes, the same sort of mortality benefit. And so, therefore, not all patients will need a central line, which then calls into question, should my goal be a mixed venous saturation or not? Because if some of my patients don't need a central line, is there something else I can resuscitate to? And so we'll talk about that next. And then looking at the hourly IV fluid volume, the protocol-based therapy patients actually had about 1 liter more than others, but didn't seem to have any additional mortality benefit with that. And it sort of echoes what was seen recently in the sort of retrospective big data article in the New England Journal, where they didn't see a mortality benefit with like timely IV fluid resuscitation. It really is treating the source of the distributive shock, making sure that's assessed. Obviously, you don't want to cause end-organ hypoperfusion in the meantime, but really thinking about what the source of the infection is and starting empiric antibiotics early. So you'll hear from Dr. McConville about how a static CVP is no better than a coin flip in terms of determining volume responsiveness. So we'll go beyond that and then look at everyone's favorite topic of crystalloid versus colloid and its use in septic shock. So there was an initial study by the SAFE investigators where they took patients who needed resuscitation regardless for their cause. And they randomized them to receive colloid with albumin or crystalloid. And when they did a subgroup analysis, they found that patients with severe sepsis, this is by the old definition, and so the old definition was you have SIRS plus infection and you have end-organ hypoperfusion. What they found was that if you gave them albumin, they actually had a trend towards improved survival. And so this sort of created a lot of interest in seeing if maybe colloid is preferred to crystalloid for resuscitation for septic shock. And so that trial was completed 3 years ago, is the Albios study, where 1,800 patients were with severe sepsis, meaning sepsis plus end-organ hypoperfusion, were randomized to albumin versus crystalloid alone. And again, this is the Kaplan-Meier curve and no difference in survival. And so it doesn't mean that one is worse than the other, it just means that they're about equivalent. And so most people are sort of going for what's easy and picking crystalloid. So the next question becomes, is my MAP goal appropriate? Is the MAP of 65 sufficient for adequate end-organ perfusion? And the reason why that's even a question is that when you think about autoregulation, which basically is a term that suggests that organs can modulate blood flow to the organ to provide adequate blood flow across a certain range of mean arterial pressures. So if you're normotensive and you stay with a MAP around 55 or so to like 125, you can maintain adequate blood flow. But patients who have baseline hypertension actually shift their autoregulation curve to the right, such that a MAP goal of 65 will lead to a lower organ flow, and therefore these patients are vulnerable to having kidney injury or other organ injury from poor perfusion with lower MAP goals. And so one group actually looked at that, where they looked at patients who had acute kidney injury in the black squares and those who didn't have acute kidney injury in the white squares. And if they presented to the hospital and you look at their MAPs across their hospitalization and they don't have septic shock, there's no difference between the MAPs of patients who develop kidney injury versus those who don't. But those who developed septic shock, actually, the patients who developed acute kidney injury in addition to their septic shock had lower MAPs than those who had no kidney injury whatsoever. And therefore, some were arguing that maybe we should target a higher MAP goal for those patients who have shifted autoregulation curves. So that trial was actually done 3 years ago, looking at high versus low blood pressure targets for patients in septic shock. The high target group had a MAP goal of 80 to 85 versus the low target group was 65 to 70. And the primary endpoint was mortality at 28 days. I should say that the patients they enrolled were all kinds of patients, but they did stratify based on the baseline history of hypertension, so they could get to the question of, is autoregulation playing a role here? Unfortunately, there was no difference in survival with the overall population of patients, whether you targeted high or low group. In the patients who did have a high target group, what they found was that the patients with chronic hypertension actually did have less need for renal replacement therapy, and so that might be a subgroup that you could target a high blood pressure goal for. But unfortunately, it's at the expense of a lot of dysrhythmias, so patients in the high target group had a lot of atrial fibrillation, because you can imagine you need a lot of vasoactive agents to achieve that higher MAP goal. So now let's talk about mixed venous saturation. We reviewed that in the PROCESS trial, about 40% of the patients did not require a central line, and so what target would you then achieve when you're trying to achieve your resuscitation goals? And so one group looked at lactate clearance, which is defined as looking at the initial lactate and then subsequent lactate checks after resuscitation, and trying to aim for at least a 10% decline in lactate with your resuscitation efforts. And they asked the question, is that just as good as getting a mixed venous saturation? So they designed a non-inferiority trial. So they're not trying to say one is better than the other. They're just trying to say that they're both just as good or just as bad together, no difference. So now what they found in the lactate clearance group, that the patients in the lactate clearance group had similar in-hospital mortality as the mixed venous saturation group. Interestingly, the percent difference is there, but it didn't reach significance to say that one is superior to the other. So we can just say that they're non-inferior to each other, and that there also was no difference in complications in the hospital or ICU length of stay. And so it seems that lactate clearance is probably just as good as getting a mixed venous saturation when you're resuscitating septic shock. So let's talk a little bit about the quagmire of steroids in septic shock. And the reason why this keeps coming up is that there are data to suggest that patients will develop a relative adrenal insufficiency while they have septic shock. Inflammation can create a glucocorticoid receptor resistance, so whatever cortisol is available may not be as effective. And that, sepsis, at least initially, has a very pro-inflammatory phase that may be kind of exuberant, and so you would like to tamp that down with some steroids. Unfortunately, measuring cortisol can be complicated, so often a lot of labs will just do total cortisol, but that doesn't tell you how much is available to the tissues, because often patients have low albumin levels. Sepsis can actually reduce the cortisol binding protein that's available, and so you don't really know what the true biologically available cortisol is. And then to make things even more confusing, the ACTH stim testing that you do to sort of identify people who respond or don't respond can be a little bit inaccurate in the setting of sepsis. Often you can have spontaneous increases in cortisol in the absence of stimulation. Maybe if you tested the same patient twice in the same day, they sometimes don't have the same result. And then in addition, some medications can alter the cortisol synthesis, especially etomidate. So if you use that in your rapid sequence intubation, you can have low cortisol levels and think someone's a non-responder when they are. So with all that, there were initial trials that suggested that there was a benefit. So everyone quotes the Anani trial, where they took patients in septic shock, gave them hydrocortisone and fludrocortisone versus placebo. They did test patients and sort of stratified their results based on whether you responded to a cosentropin stim test or not. And what they found was that if you don't respond to a cosentropin stim test, those patients had a mortality benefit of about 10%, and that they were on vasopressors for a shorter period of time. This study was actually repeated by another group, a larger study. They looked again at non-responders to the cosentropin stim test and gave them hydrocortisone. And what they found was similar, that there's a quicker resolution of shock. However, in the 48 hours of enrollment in the trial, they developed new infections. So there was a higher rate of superinfection and obviously all the other complications with steroids, such as hyperglycemia, et cetera. And then there have been many meta-analyses incorporating these data and other smaller trials, which give conflicting results. So it was really hard to get a sense for what the right way to go for steroids and septic shock was. And then finally, there was a trial recently done last year thinking about, well, maybe you shouldn't wait till someone's on a pressor to then say, I'm going to give you glucocorticoids to get you through this. We should take patients who have sepsis with end organ hypoperfusion but are not on a pressor yet and see if we can avoid them needing a pressor and progressing into septic shock. And what they found was that addition of steroids in that scenario didn't change the outcomes either. So now the Surviving Sepsis campaign guidelines really kind of put all these data together and said that if the patient has hemodynamic stability that's restored with fluids and vasoactive agents, probably not the right person to start hydrocortisone on because of the risk of superinfections. But if that's not achievable, meaning patients are in refractory shock, that's the scenario where patients can potentially benefit, although there's no trial with that, and so it's sort of a weak recommendation based on expert opinion. So to summarize septic shock, early identification is key, which is why this new sepsis 3 definition was developed, so that you can sort of identify people who are at risk just at the bedside using a quick SOFA. And then administering antibiotics seems to be associated with improved survival. There's no difference in what protocol you use, really, because I think usual care has really gotten better since the Manny Rivers trial, and you can use other endpoints like lactate clearance, et cetera, to not necessarily need a central line. And then finally, it's important to guide resuscitation end organ perfusion, and recent trials have shown that a MAP of 65 is just as good as a MAP of 80 to 85, using crystalloid in the setting of septic shock, and then lactate clearance as a goal. So let's end with vasoactive drugs, and we'll talk a little bit about the receptors they affect and the different medications and their targets. So first, alpha receptors, alpha-1 specifically mediate vasoconstriction because they're located on the smooth muscle of vasculature. Alpha-2 is actually more CNS related, so that you'll see an agonist primarily in dexmedetomidine, so it's for analgesia, not really for hemodynamic effects. Beta receptors, beta-1s are located on the heart. They mediate contractility and heart rate. Beta-2 actually can improve some coronary perfusion by dilating coronary vessels. And then last, dopamine works on dopaminergic receptors, but also on alpha and beta. And so depending on the dose, you could have increasing veno and arterial constriction. There were kind of old data suggesting low-dose dopamine may improve renal perfusion. There are 2 studies in the Lancet and JAMA that sort of don't really see that effect. In fact, in some settings of septic shock, the dopamine can actually shunt blood flow away from the mesentery, so it seems that that's less of an effect than previously thought. So this table summarizes the general effects of all vasoactive agents. Phenylephrine, as you know, is primarily an alpha-1 agent, so it really mediates the systemic vascular resistance. Norepinephrine is alpha-1 and beta-1, and with this beta-1 activity can also improve some cardiac output. Epinephrine affects all 3, so alpha, beta-1, and beta-2. Dopamine, again, with the increasing doses, will have increasing alpha and beta effects. And then dobutamine is purely a beta adrenergic receptor and therefore improves cardiac output. Vasopressin works on the vasopressin receptor and mediates blood pressure by vasoconstriction, and so primarily increases afterload or SVR. So we'll have another question. This is a 58-year-old man with diabetes and hypertension who presents with substernal chest pressure. The vital signs reveal a blood pressure of 70/50. His heart rate is 114 breaths per minute. His breathing at 32 breaths a minute and saturating 90% on room air. He has distended neck veins, cool extremities, and delayed cap refill, and crackles at the lung base. His EKG shows ST elevations in the anterior leads. The cardiac cath lab is activated and a vasoactive agent is ordered. Which of the following is true about the choice of vasoactive agent in this context? A, dopamine is associated with increased mortality. B, dopamine is superior to norepinephrine in the treatment of shock. C, atrial fibrillation is more common with the use of norepinephrine than dopamine. Or D, vasopressin has been shown to improve mortality. All right, so about 70% of you picked A, which is the right choice. This is based on the DeBacker study, and we'll talk a little bit more about that. So the DeBacker study, published in New England Journal 7 years ago, randomized patients with all types of shock, and they randomized them to receive dopamine or norepinephrine, and they looked at 28-day mortality. And although there was no significant difference, there clearly is a trend that norepinephrine had improved survival compared to dopamine. Interestingly, they looked at the rates of adverse events like arrhythmias, and there was a doubling of the arrhythmic events in the dopamine arm. And when they looked at different subgroups, specifically cardiogenic shock, they saw an increased 28-day mortality with that. Let's talk a little bit about vasopressin, which has also been studied in clinical trials. The idea being that when you measure vasopressin levels in patients in septic shock, there seems to be a relative deficiency. And so some have thought that perhaps that repleting that can improve vascular competence. And that also vasopressin can increase your urine output, so would help with a little bit of renal perfusion. And that doesn't have the intestinal ischemia events as the alpha and beta drugs do. One group observed that adding vasopressin to norepinephrine spared how much norepinephrine you needed, and therefore you had less risk of arrhythmias or AFib because you're not stimulating the beta receptor. If you look at all comers from this trial where they did norepinephrine versus vasopressin and norepinephrine, there was no difference in 28-day or 90-day mortality, but the group had sort of set a priori patients that they defined as less severe septic shock, meaning you needed norepinephrine of 15 mics per minute or less. And in that group, when they did a subgroup analysis, they saw a mortality benefit. The problem with that logic is that you have to then know ahead of time that your patient has like sepsis light, and that's hard to know. And so, you know, I would say, I don't think there'll be a question regarding like whether you should add vasopressin or not, but if they say that the patient has, you know, 15 mics or less of treatment, what's the next vasopressor you want to use, perhaps you could start vasopressin. So this is another summary of all the trials, and I'll sort of talk about the reasoning of how we arrived to norepinephrine as a first-line choice, again, based on expert opinion, but kind of combining the knowledge from these trials. So Anani, the same Anani who did the corticosteroid trials, did a trial comparing norepinephrine and dobutamine to epinephrine. It's interesting because norepi hits alpha-1, beta-1, and dobutamine does beta-1 and beta-2. And so that was comparing it to epinephrine that hits all the same receptors. And so the 28-day mortality was not different between groups. Myberg and colleagues did a norepinephrine versus epinephrine trial, seeing if there's any benefit to the beta-2 stimulation with epinephrine. And there was no difference in how many days you were vasoactive drug-free, but they did notice that with epinephrine, as you all know, that there can be a lot of tachycardia, a lot of arrhythmias. There can also be metabolic effects where it alters metabolism such that lactate can actually rise. So if you're using that as your lactate clearance as your goal, it can be complicated in the setting of epinephrine. And so some patients actually were withdrawn from the epinephrine arm because of that problem. Russell and colleagues did the trial that we just talked about where norepinephrine was compared to norepinephrine plus vasopressin. And so the mortality benefit was not different between the overall groups. And then finally, DeBacker and colleagues compared norepinephrine to dopamine, and again, more arrhythmias with dopamine and perhaps more mortality with cardiogenic shock and dopamine. And so this is sort of the evolution of how epinephrine fell out of favor and norepinephrine seemed to be winning out and compared to other vasoactive agents, and therefore has become the first-line recommended agent by the surviving sepsis guidelines. And finally, most recently, there was a norepinephrine versus vasopressin study that was published last year. Their primary outcome was kidney failure-free days, and I think they chose this because it's an easier outcome to hit than like a 28-day mortality. And what they defined as kidney failure-free days was no acute kidney injury and no need for renal replacement therapy. They found no difference in the kidney failure-free days, but they did find that if patients were randomized to the vasopressin group, there was less renal replacement therapy needed. And I think part of that is we know that a trigger for renal replacement therapy is oliguria, and if you give vasopressin, you will have increased urine output. So there's less of a clinical impulse to start renal replacement therapy early in patients on vasopressin. So I hope at the end of this talk you'll be able to assess cardiac output and volume status in order to develop a differential diagnosis of the shock, and then use that as a hypothesis for your therapeutic intervention, and then target your goals really for end organ perfusion and not sort of arbitrary blood pressure. Thank you.